Okay, so we're ready to start then, Kieran. I'm going to send you live now, okay?
Prynhawn, good afternoon and welcome. My name is Kieran Humphreys. I'm a consultant in public health with the Wider Determinants of Health Unit of Public Health Wales, and we host the Public Health Network Cymru team. I'm very happy to welcome you to the third webinar of the series. As a network, we've had to adapt in many ways to the challenges of COVID, and one of the ways has been to undertake these webinars instead of in-person events. And I think obviously COVID has been a challenge to all of us, but one of the major challenges we have is just keeping track of all the changes that the world is facing during this pandemic and what it means for us. So this is why I'm really pleased that today we've got a webinar which is going to look at the International Horizon Scanning workstream, which helps us understand both the challenges and the solutions that are being faced across the globe in response to the pandemic. So we've got 5 speakers that I'm delighted to welcome today from the World Health Organization Collaborating Centre for Investment in Health and Well-being of Public Health Wales. They're going to talk us through that work and what they've found, and afterwards we'll have a chance for some questions and answers. So please do send in your question to us as we go along in the question and answer boxes. They will be reviewed, and if you've got technical queries, drop them in. If you've got questions for our speakers, they'll be reviewed and published, and we'll come to them at the end. We'll also have an evaluation form, so do give us your feedback today. And we're going to start off. I'll hand you over to Lauren Cousins, Senior Project Manager from the Collaboration Centre. Thank you, Lauren.
Thanks, Kieran. Good afternoon, everyone. Thank you for joining today's session. I must say it's wonderful to see so many of you interested and able to join in such challenging times, so very welcome. Before I begin, I'd just like to extend my thanks to Public Health Network Cymru for inviting us to take part in the session today, and we're delighted to be able to share the work we've been doing over recent months. So next slide, please. Okay. So, as Kieran mentioned, we're responding to the COVID-19 outbreak in multiple ways across the organisation, and I'll be focusing on the work we're doing in the WHO Directorate that's based within Public Health Wales. So there are many ways that we're responding within the Directorate, and they're listed on this slide. The one we'll focus on today is the horizon scanning, but there are other projects that are taking place, such as the National Public Engagement Survey, which also produces bi-weekly reports, and that's a survey which just speaks to people across Wales and tries to find out about their experience of the lockdown. And so far it's spoken to about 8,500 people, so it's quite comprehensive. So if you do have an interest, please look that up also. It can be found on the same link that we'll signpost at the end of the presentation. But as mentioned, the focus of today's presentation is to give an overview of the work we're doing to explore international evidence, and we refer to that as the International Horizon Scanning reports. So we try to look at how this evidence might be used to inform the Welsh response to COVID-19. Next slide, please. So briefly, the purpose of the work is to provide a high-level synthesis of the available evidence, and we focus that on a specific topic or multiple topics and try to present it in a way that's easily digestible, or more digestible than sifting through all the reams and reams of evidence that's available at the moment. The way that we go about it is to follow a methodological approach. So we have been working on the approach as the project developed. So we started work on the horizon scanning back in April, and it's been a developmental process really, just to learn ourselves how to identify the topic information, where to go for the best available evidence, and try to make sure that that evidence is robust. So we start off the process by being given a topic of interest. So that topic would most likely come from Welsh Government, but also we sometimes take them from Public Health Wales internally. So if colleagues have got an interest in a particular area, usually they come from our Gold Command team. And then those topics are then allocated across our team, and they go away and have a look at the available information, carrying out searches and checking websites such as the World Health Organization or ECDC, for example. And then the information is synthesized. So basically it's all sent through to one person to synthesize and bring it all together and check, make sure the references are robust, and there's a final edit that's done by a consultant lead prior to publication. So some of the topics that we've covered most recently are shown on the slides here. So you can see the box that says in focus this week. So we were having a particular look at the divergence in trends. So we've seen differences in the age profile, for example, of the infections. We've also had a look at the impact on children and young people and mental health and well-being in the most recent report. So one of the things we found is that as time's progressed, the topics have become much more specific and technical. So if you do go back to the initial reports, you'll see that they're a little bit broader and more generalised, and as they go on, they then become much more specific with the questions. So they cover quite a wide range of topics. Okay, next slide, please. So initially, when we started doing the horizon scanning reports, we were doing them on a weekly basis, and that has now dropped to bi-weekly. So as I mentioned, the reports contain a wide range of information, and some of the types of information is shown on this slide. So within the topics that we receive, we have epidemiological information, so it might be surveillance data from different countries, and we will then try to have a look at that data and identify any trends or emerging issues. We'll also have a look at the way that other countries are responding to the outbreak and what their recovery policies are. And that's really to try to see if there's anything that's working particularly well in those countries that might be applicable here in Wales. And then we'll have a look also at the wider socioeconomic and equity impacts of the outbreak. So, as you know, there's been quite a lot of issues with high rates of unemployment, vulnerable groups being affected, increases in violence, for example, people struggling with homelessness due to prior issues such as unemployment, and we've just really been trying to see what measures are being put in place to try to mitigate those impacts. We also have a look at in-depth country reviews. So if there's a particular trend in a country that's of interest, we'll focus on that country that week, or we might highlight several countries in a report just to show. So for example, in the mental health report, we highlighted several countries and showed a brief example of the measures they were taking within those areas to highlight good practice. So next slide, please. So this is just a slide to say where the information goes really and who uses it. So the reports are shared directly with the Welsh Government, and it goes to their Office for Science. We also link in with the Technical Advisory Group on International Surveillance, which is a subgroup within Welsh Government, and that information feeds in and is used as part of their decision-making processes. It's also shared internally with Public Health Wales colleagues with the same aim, and we then link in with stakeholders across the UK and internationally. So on the slide, there's just a few examples of some of the outputs that we show in the report. And I think it is important to note that while we're using international evidence, we do make sure that we add some caution around the use of the data. So there's sort of caveats around the data. So every country has got its own political system, social, cultural, environmental, economic variations that are impacting the response, and that needs to be considered when presenting this work. So even though we're looking to see what's being done, we do need to say also, you know, there might be a particular political situation that's helped or hindered the facilitation of the response. So that's just something to bear in mind. Okay, and then next slide, please. Okay, so the next slides that my colleague is going to present are just going to give some insight into particular topics that we focused on during the reports. We tried to choose topics that we felt would be of interest, so it's quite a wide range. The first one is looking at the longer term impacts of lockdown and how health inequalities have played a part in the outbreak. Then I'm sure many of you would have heard in the media, there's been a lot of reporting on the use of vitamin D and how that can have protective characteristics. So we'll go into a bit more detail on that and you know, let you make your mind up on it based on the evidence. We also are going to look at the safe disposal of PPE, and that's just touching on the environmental aspects of PPE use and also the production processes. And then we'll have a look at the R value in Germany. And if you don't know what the R value is, then James will explain that when he comes to it, so don't worry. So that's it from me, fairly brief. I'd like to hand over to Anna now, please, and I hope you enjoy. Thank you.
Thank you, Lauren. Good afternoon, everyone. I hope everyone can hear me now. Today, I'd like to give you a brief overview on the impact lockdown and social distancing measures have had on healthcare services and inequalities around the world. And I would like to specifically present you the evidence we synthesized in the Horizon scanning reports. We found that there's emerging evidence that the COVID-19 pandemic has impacted and even worsened existing health inequalities in countries globally. And as a little reminder, health inequalities are ultimately about differences in the status of people's health. So they are mostly avoidable and unfair differences in health between different groups of people. But the term is also commonly used to refer to differences in the care that people receive and also the opportunities that they have to lead healthy lives, both of which can then contribute to their overall health status. To give you a couple of examples, health inequalities can therefore involve differences in, for example, health status. So that would be life expectancy and prevalence of health conditions. This could also be access to healthcare, which would be, for example, availability of treatments, but also behavioural risks such as smoking rates or the wider determinants of health, for example, quality of housing. Next slide, please. Evidence we captured in the Horizon scanning report suggests that the impact directly caused by lockdown and social distancing measures could be very profound and affecting people's income, job security, also social context, as well as their health and well-being. Health services in particular have been severely disrupted, especially at the start of the pandemic earlier this year. And especially routine healthcare has been postponed or even cancelled in many countries. Service disruptions were and still are widespread in countries, and those disruptions have included delayed diagnosis, delayed or incomplete or interrupted therapy, treatment and rehabilitation, delayed care seeking for emergency, worsened prognosis, for example, in cancer care, and an increased behavioral risk, for example, physical inactivity, increase of harmful use of substances, but also disrupted immunization services. So those are just a couple of examples how healthcare services across the world have been disrupted. Next slide, please. So the WHO conducted a survey earlier this year, which was published in June 2020, and the survey was completed by member states, asking them about their experiences in terms of health services disruptions in the earlier stages of the pandemic. The survey particularly focused on prevention and treatment services for non-communicable diseases. And what the survey has confirmed is that the impact of health services disruptions is experienced globally, but that low-income countries are most affected by it. The situation is of particular concern, as evidence we found suggests that people living with NCDs are at higher risk of severe COVID-19 related illness and death. And I now would like to draw your attention onto the bar chart presented in the slide. So the main finding is that the health services have been partially or also completely disrupted in the majority of countries which undertook the survey. And if you look at the second bar from the left, for example, you can see that more than half, to be exact, 53% of all the countries surveyed have partially or completely disrupted services for hypertension treatment. And if you go on and look at the other bars, 42% experienced partially or completed disruption of cancer treatment, for example. Rehabilitation services have been disrupted in almost 2/3 of the country, which is quite high, especially because it's so rehabilitation services are so important for a healthy recovery following severe illnesses from COVID. So yeah, those are just a couple of examples of healthcare services disruption. Next slide, please. The disruption, what we have found of health services, has had detrimental impacts, obviously, on health and well-being, and appears to widen the social and economic division with very long-term consequences. And impact of the COVID-19 pandemic caused by health services disruptions are interconnected and appear to affect the most vulnerable in society disproportionately. So that touches on the aspect I mentioned first about health inequalities. And I would like to outline two vulnerable population groups who have been disproportionately affected by the impacts of the pandemic. Next slide, please. So I decided to focus on the Black Asian minority population group, also called BAME. We know that COVID is affecting this particular population group differently, and emerging evidence we found suggests that individuals from this group are at an increased risk of contracting COVID-19 and present worse clinical outcomes. Data on ethnicity in patients with COVID-19, however, remains limited. There is limited evidence of health-related effects of interventions aimed to support socially or economic vulnerable groups exposed to the COVID-19 pandemic. Next slide, please. Yeah, you should be able to see those two groups now. Yeah, so the second group I focused on are people experiencing homelessness or at risk of homelessness. We know that this is a very vulnerable population group, and exposure to COVID-19 can negatively affect their mental and physical well-being. People experiencing homelessness aged younger than 65 years of age have all-cause mortality that is 5 to 10 times higher than that of the general population, for example. And especially with healthcare services so severely disrupted, this particular population group can be even more overlooked, as obviously most of the services are allocating their resources to fighting the COVID-19 pandemic. And especially detecting of cases and prevention of the disease in a very transient population group are very difficult. And many people in that group live in congregate settings such as shelters or halfway houses, which obviously increase the risk of transmission of COVID-19. And obviously, in general, the COVID-19 outbreak can impact housing security with obviously loss of income, causing rent or mortgage difficulties, or if worse comes to worse, even homelessness. If we could go to the next slide, please. And to summarize, over the past couple of months, we have noticed severe health services disruptions due to the pandemic, and disruptions have exposed the pre-existing inequalities in society, affecting the most vulnerable population groups disproportionately. Therefore, do we need to create a much more fairer society to improve the health of the whole population and ensuring a fairer distribution of good health. Thank you for listening. I'm now handing over to my colleague Nisha, who will be talking about vitamin D deficiency.
Hello, hi everybody. I will use my 6 minutes to speak about the link between vitamin D and COVID-19, a rather specific topic that we have been looking into, but one that immediately attracted my attention and I was keen to explore in more depth, and also now today to present to you. As you can see here, there are in general, and not necessarily in relation to the COVID outbreak, a wide variety of social groups that have been affected by vitamin D shortages in our society. For example, in some countries in Europe, almost half of the pregnant women suffer from vitamin D deficiency, with this percentage being even higher in BAME populations. Addressing this specific issue can, for example, help to reduce the incidence of early childhood asthma. This is just to highlight the importance of addressing this topic here today, and also why we have included it in one of our reports. Other illnesses in the general population linked to vitamin D deficiency include cardiovascular disease, cognitive impairment in older adults, cancer, diabetes, and multiple sclerosis. In terms of causes, limited sun exposure is probably the best known cause for all of us, but there are a number of other causes that I've just listed here for completion. Next slide, please. I think this slide really nicely shows that vitamin D deficiency is a real issue in the UK and the rest of Europe. In Europe alone, 10% of the population is having severe vitamin D deficiency. And as you can see on the right, this deficiency is not equally divided over the countries. As you can see, there's a huge discrepancy between the southern and more Nordic countries, especially looking at the difference between, for example, the Scandinavian countries like Sweden, Norway, and Italy. This discrepancy is also known as the vitamin D paradox. Some of you may have heard about that one. Causes for this paradox are numerous. Some of the key causes in the literature are the in general higher presence of pigment in the darker skin in the population in the southern part of Europe, which reduces the absorption of vitamin D, the increased usage of sunscreen, for example, to protect against skin cancer, and the reduced time spent outside for exercises due to the more urban environment in the southern part of Europe in comparison to countries like Norway and Sweden, where everything is much less urban and more open and people are much more outdoorsy, and they also, very important to mention, have a lighter skin and have a diet fortified with vitamin D. I will elaborate on the latter point in a minute. Next slide, please. So vitamin D may have become an even more pressing issue now following the COVID-19 outbreak, and I think this is my main slide for today. First of all, we're spending more time at home following the contingency measures put in place. In the first week of June, 13% of the people in Wales had not left their home or garden, and this percentage was probably even higher for the second part of March, in April, and in May. In addition, the rest of the population has most likely also been less outdoors, further contributing to possible vitamin D deficiency following the reduced exposure to sunlight. Following the links that I've mentioned earlier between vitamin D and many severe illnesses, a spike of vitamin D deficiency could have a real adverse effect on the population in Wales. Secondly, what I would like to highlight, and I would like to take you now to the blue box, even though there is no conclusive evidence that vitamin D supplements help to prevent or treat COVID-19, NICE and The Lancet agree that vitamin D may have a role in the body's immune response to respiratory viruses, including COVID-19. A randomized control trial referred to by The Lancet concluded that vitamin D supplementation protects against acute respiratory tract infections. So while nothing is conclusive, you could argue, as some experts do, that there is sufficient circumstantial evidence available to stimulate the intake of vitamin D. I know that, for example, in Spain, doctors are prescribing people that have been diagnosed with COVID-19. They give them vitamin D supplements. A final point what I would like to make here is the relation to the contingency measures that has some indirect effects on population health. So Anna already extensively elaborated on that. But the example that I would just like to briefly mention here, just because it's so relevant for the link between with vitamin D, is hip fracture care, which seemed to have been distorted by the COVID-19 outbreak, even though also here the evidence is not conclusive, with other reports, with other literature reports saying that that's not been the case. Administering vitamin D could potentially help to address the pressures on care services, for example, for fracture care, but also to address some of the other diseases that I mentioned earlier and that are linked to vitamin D deficiency. Hereby noted that for other disease areas, the link with vitamin D shortages is often limited. Next slide, please. So in relation to COVID-19, the Public Health England and Welsh Government recommendation have issued for the general population to take a daily supplement of 10 micrograms following staying-at-home measures. Northern Ireland have similar recommendations in place. So all the measures that I've outlined here below are not necessarily in relation to the COVID pandemic, but are just measures that most of them were already in place before that, and just could possibly inspire us here in Wales, some of our policies to see how we can address this issue effectively here as well. As we may remember from one of the previous slides, deficiency before the pandemic was 20% in the UK, and we don't really know how COVID may have affected that percentage in an adverse way. Next slide, please. So in conclusion, vitamin D deficiency is an issue and may have been worsened due to the coronavirus situation, in particular the national and also the current regional lockdowns that many of us unfortunately have to face now. Countries have implemented different approaches to address vitamin D deficiency, and as I think we have clearly seen from the slides, especially the Scandinavian countries have been very successful in reducing this deficiency among their population, so maybe there could be some lessons learned from them. And finally, the UK and Welsh Government are stimulating the intake of vitamin D supplements to the entire population. It was a measure directly in relation to the coronavirus outbreak, and this advice can be read here in the right box. I'm going to hand over now. Thank you for your attention. I'm going to hand over now to Angie, and if you have any questions for my presentation, we can do that during the Q&A later on. Thank you very much.
Thanks, Misha. Pranhanda, good afternoon. So I'm going to talk a little bit about PPE and the disposal of PPE. So I proposed this as a topic as I was becoming quite concerned about PPE litter in my local neighbourhood, and I was thinking about the amount of disposable masks and gloves being used by the general public in the wake of COVID-19. And from a sustainability perspective, I wanted to examine how we currently manage how we currently manage this additional waste and what the impacts could be if we don't manage it well. So if we just look to the left-hand column, so these are the numbers of PPE issued in Wales and the UK for clinical use. Obviously, these numbers are quite large, and hospitals have their own process for dealing with contaminated waste. And if we look to the right-hand column, and that's also something that doesn't exist for the public, by the way. So looking to the right-hand column, this is the potential waste that could be created if everybody in the UK were to adopt single-use mask use on a daily basis. obviously the numbers are quite staggering. Especially looking at the fourth bullet point there, it would create 10 times more climate change impact than reusable masks. Now, obviously, it's quite unlikely that everybody in the UK would adopt single-use mask use on a daily basis, but I think this shows even widespread usage would be could have quite detrimental climate impacts. So if we just move on to the next slide, please. Okay, so so what's the environmental context and what happens when PPE enters the environment? So in 2018, the UN Environment Programme estimated that around 13 million tonnes of plastic enter our oceans every year, with huge impacts on biodiversity, economies and potentially health. Worldwide, reports are growing of discarded PPE in public places and marine ecosystems. I'm sure many of you have already seen evidence of this in shared public spaces such as local green spaces, streets, supermarket car parks. Unfortunately, there is a growing number of reports about PPE pollution in the marine environment. For example, environmental NGO Oceans Asia discovered piles of discarded masks washed up along a stretch of coastline on the Soko Islands in Hong Kong, with more being brought in on the tide. In France, divers discovered dozens of masks, gloves and bottles of hand sanitizer littering the ocean bed along the Côte d'Azur. And so disposable single-use masks are usually made of polypropylene and other composite plastic materials. Polypropylene is a dense thermoplastic which is non-recyclable and non-biodegradable. As we know with plastics, they don't simply disappear when they degrade, they just break down into ever smaller particles, microplastics, which can then enter the food chain when consumed by crustaceans, fish and other marine species. Surgical gloves are usually made of synthetic polymers. There's a few examples on the slide. So as these break down in the environment, they release persistent organic pollutants, which are harmful toxins, which damage marine health, enter the food chain and leach into soil from landfill. So in addition to the potential for environmental contamination from discarded PPE, it also poses a risk to wildlife, entanglement, choking hazards, ingestion, for example. I'm sure many of you have already seen footage of birds trapped in the elastics of discarded face masks. And so all of this comes at a time when countries are also experiencing a huge surge in single-use plastics as a result of the shift back to plastic packaging and bans on reusable cups, for example. Okay, so if we move to the next slide, please. Thank you. Okay, so disposal. Unlike hospitals, no segregated waste streams exist for the general public to safely dispose of potentially contaminated PPE. If not disposed of correctly, when added to general waste or mistakenly added to the recycling, for example, they can be a potential source of infection for people handling the waste, for example, cleaners and waste disposal employees. Okay, if we move on to the next slide. Thank you. Okay, so supply chains and ethical procurement. Okay, so China is the world's largest producer of surgical masks. And between March and May this year, China exported 70.6 billion masks globally. So this compares to global production of around 20 billion masks in 2019, with China then accounting for half. And there are serious concerns of forced labour and human rights abuses in PPE exported from China and Malaysia. Which really reinforces the need to take action on ethical procurement. And so the UK government has actually introduced new measures to tackle slavery in supply chains. And so these new regulations will require public bodies in England and Wales with a budget of over 36 million, this includes local authorities, to regularly report on what they are doing to prevent slavery in their supply chains. If we move on to the next slide, please. And legislation and policies that guide public bodies in Wales include the Wellbeing of Future Generations Act. In particular, the goals that link strongly with this issue are the globally responsible and resilient Wales goal. And so under the globally responsible Wales goal, public bodies have to think about global well-being when they in their actions to improve economic, social, environmental and cultural well-being in Wales. It also means they have to ensure their supply chains are fair, ethical and sustainable. And linking back to the potential impact of PPE litter once it enters the environment, the Resilient Wales goal means that public bodies must act to maintain and enhance biodiverse natural environment and healthy functioning ecosystems. And then finally, the Welsh Government's Code of Practice on Ethical Employment in Supply Chains also aims to protect workers and eradicate unlawful and unethical employment practices. So that's a really brief look at the social and environmental impact of PPE and the policies that can help guide public bodies in tackling this issue. So if you would like to investigate further, there are links to resources and further reading at the end of the slides, and you can view the full report via our IHCC website. Diolch yn fawr iawn, thank you. Oh, and on to James.
Yeah, thank you, Angie. Bryn good afternoon all. I hope everybody can hear me clearly. I'm going to give an overview today of our work that explores the impact of restrictions on the R value. I'm sure we've heard lots about it over the past months, so yeah, let's get into it. First, we're going to start off by asking the question, what is R? So R is the reproduction number. This is the mean number of people infected by one infected person. It's not something that can be extracted directly from a notification system, so it's usually estimated retrospectively, so looking backwards. When disease modelers look to generate R, they usually look at current and previous case numbers and deaths. And after making assumptions to find an infection number that could explain the trend, they're able to derive an R value. In simple terms, an R value greater than 1 means that the number of cases is increasing exponentially. If the R value is less than 1, it means that the disease will eventually stop spreading. Next slide, please. Great. So what did we set out to achieve as a team? We certainly saw value in linking the estimated R value to the imposing and lifting of measures designed to prevent the spread of the virus. We knew we wanted to look at other countries to see if there was any learning that could be considered here in Wales. And we wanted to generate insight aimed mainly to inform the thinking of policymakers here in Wales. I think as a team, we felt it seemed logical to, given at the stage of the pandemic where the work was undertaken, mid to late May, to look at other European countries and see what they were doing, particularly because they were slightly more advanced in terms to how the virus was spreading. So it made sense to us. Next slide, please. So what data and information did we need to set out what we wanted to achieve? So to conduct the work, we knew we needed timely reports providing a regular estimate of the R value. We also needed contextual information relating to changes in policy, legislation and whatnot. We also needed to consider media articles to capture any changes that may happen at a very local level. Something I want to come on to a little bit later around local changes. Next slide, please. So our efforts led us to Germany. At the time, they were one of the few countries that frequently reported an estimated R value. The Robert Koch Institute provides a 7-day point estimation of the R value, and the German Ministry of Health website provides details on the imposing and lifting of restrictions. Also provides a lot of information around COVID related tools, the announcing of applications on mobiles and whatnot. So yeah, a very detailed resource. Next slide, please. So looking at a technical level, what did we do? We extracted the data from the Robert Koch Institute website, and we linked this to policy changes documented on the Ministry of Health website, and allowed us to see the trend in the following way. Next slide, please. So the chart with the accompanying narrative allows us easily to see change over time. This chart shows us the R value from the beginning of April until the end of August. One thing we should say, we appreciate the situation is highly dynamic and estimates continue to fluctuate. Data for September, not shown here, already shows that the most recent R estimate is above 1. We can see here that the R value fluctuated between around 1.4 to 1.5 estimated mid-June. This was similar to when the Corona Warn app was launched in Germany, to a low, I guess, of around approximately 0.7 towards late June. Another observation, I guess, is that there's been considerable fluctuation in the R value since mid-June compared to the start of the pandemic. Next slide, please. A few notes that I wanted to capture around the work that we did. So it's important to say that causality cannot be determined. Rather than determining causality and saying, oh, this has been introduced and it's had this effect on the R, we really wanted to just contextualize the R estimate, certainly in a policy context. Yeah, another thing I wanted to raise was that the R estimate is quite susceptible to local outbreaks. So the large peak in the middle of the chart, from reading articles lately, it seems that was due to an outbreak in a meat processing plant. And so it's quite sensitive in that respect. It's also important to say that the R value is just one of many metrics which policymakers use to help make evidence-informed decisions. They also need to consider the number of new cases, the number of deaths, number of hospital admissions. It's just trying to make it clear that it's just one aspect. Next slide, please. So where has the work been used? Yeah, it's featured in the work of the Technical Advisory Cell in Welsh Government, specifically the report published on the 8th of June. The summary of advice on the impact of European measures to ease lockdown restrictions on the R value has also been featured in the areas that Laura mentioned earlier in the presentation. Next slide, please. So that's all I got to say about R for the moment. In terms of next steps, I think Laura mentioned this, but if anybody missed it, the Horizon Scanning reports will continue on a bi-weekly basis, so once every 2 weeks, mainly covering emerging trends. They can be found at the Public Health Wales website, detailed on the slide, also the IHCC website. I also wanted to just take the opportunity to promote our latest Twitter account, so that's detailed there, PHWHOCC, and also the IHCC Wales account. That's all from me, so happily pass back to the chair, Kieran.
Thank you, and thank you all for those really interesting presentations. Just to say, I know quite a few people had some difficulty joining us, so our apologies for that. All the presentations will be recorded on the website, and thank you for bearing with us. We've had a lot of interest and very positive remarks come to us in our Q&A boxes, and some of the vitamin D has raised a lot of questions. So Misha, if I could ask you some questions that have come in relation to that. One is a straightforward question about the recommendations for vitamin Ds, asking, does this apply to children under 10 years old?
So there have been like specific recommendations for children, especially for children like to an age of 3-year-olds, because they are like so early childhood, because they are especially at risk of limited vitamin D exposure. So a lot of different countries, they have recommendations for this specific group to have a supplement. And I think if you've seen on one of the slides, for example, in Turkey, they get actively vitamin D supplements from their GP. I'm not sure what would be for the age group between 3 and 10 years old, but I can imagine there's less risk. But I'm not able to in a position to say like whether we should or should not give that specific age group or more vitamin D.
Okay, thank you, Misha. I think there's also for Wales specifically, there is some information on the website for the person asking the question as well to look for what's recommended there. Another question, I don't know if you can answer this. One of is an interesting one, which is there a best time of the year or time of the day to get vitamin D, or even a good part of the body to expose?
I've read that there is a recommendation that if you would go between, I think it was around 2 o'clock or 2, like I cannot be that specific, but let's say 2 or 3 o'clock in the afternoon, that is like one of the best times to be outside and expose yourself to the sun. But I'm happy to look into that again, and then we can come back on that question in our
yes, and as we head into winter, it may we may behave a bit differently than we would in the summer months. Another question about vitamin D is about the socioeconomic inequalities and whether that translates into issues with vitamin D. And the question particularly highlights that people may have differences in whether they can afford to buy supplements or even have access to a garden where they can go out and spend time, particularly when we're in a more lockdown period.
So there's not that I've come across that there is any specific evidence on that, which doesn't mean that it cannot be the case. And we have seen that especially the Bama population has been really hit very hard by the COVID outbreak. And there may be a link there also with their vitamin D shortages, which I also mentioned in the slides, that can also be related to their darker skin, which is then which produces more pigment, which then makes it more difficult to absorb the vitamin D. But there can of course also be other causes. And I mean, logically, you would indeed think that people, of course, that are not able to sit in their garden in the sun during, for example, the current some of the regional lockdowns, that they are affected more.
Yeah. Thank you for that, Misha. Anna, if I could move on to yourself, we've had a few questions around healthcare, and one is, was there a difference in access to healthcare between primary and secondary care type services, or between planned long-term care compared to emergency services?
I'm not sure if I can give you an answer which is 100%, but from what I've read from WHO is that countries obviously had to prioritize services, and I know that around 90% of countries reported some sort of a disruption to essential services, and most routine and elective services have been suspended due to the ongoing COVID-19 pandemic, and are slowly being picked up now. And mostly disrupted have been routine immunization services and facility-based treatments, obviously. And what I talked earlier in my slide about NCD diagnosis and treatment, they have significantly dropped in the past couple of months. But obviously, at the moment, countries are trying to adopt their services to the needs and trying to get through the pandemic in order to serve as many people as possible. But I would probably have to look a bit more into that to give a better answer to that question.
Thank you. And I think, yeah, and you're certainly reflecting that the routine services are hit harder, aren't they, from what you said? And I guess another interesting question about the experience of other countries. I don't know if you've got any insight into whether some countries have managed to continue their services better than the UK, and if so, which ones they are.
I can only speak from Germany, if that's okay. Just because I've got a bit of experience. I know that in Germany, more routine healthcare services have been kept open, especially through the first wave of the pandemic, in order not to create a backlog of services. I know that compared to the UK, especially, I know that was the case. That's all I can say on that. Sorry.
That's great. Thank you. It's good to have that insight. Angie, we've had a lot of interest also in the experience of the PPE that you've described. I think you've kind of managed to encapsulate how we've seen our efforts to focus on future generations and prevention and a sustainable future are getting challenged by this pandemic. We've had a question, do you know which countries are doing the best job of managing the impact of discarded PPE?
In addition, France, actually, when I was looking into this, France, when all those masks, gloves and bottles of hand sanitizer were discovered, France immediately went into action and put very big bans, fines, on PPE littering. And so that all happened almost immediately after that news was broadcast. And actually, when we started looking into this, it was rather too early to kind of identify good practice. It's only just happening now. So, hopefully we'll be able to see some more evidence of good practice coming up over the next few months. But yeah, initially when we looked, there wasn't that much out there, unfortunately.
Thanks for that. And another question is, do you think it's better to use washable PPE?
Oh yeah, definitely. I mean, there's one of the studies I looked at was from University College London, the Plastic Waste Innovation Hub there, and they did a huge study into the environmental impact of PPE, which is where I got some of that data from, and they compare washable, reusable masks with and without filters in comparison to disposables, and you can have a look. It's linked in the resources, and it shows the kind of environmental impact for every element in the stage of the production and creation of those masks, and then also how the climate impacts of then washing them if you're using reusable. So definitely washable, having it on rotation would be like much better in terms of environment and social impact as well.
Thank you very much. On to James then. We've there's a question on whether or not other countries were more advanced in their approach because they had more positive cases earlier or more cases altogether. So just wondering what your thoughts on that are.
Yeah, that's really picked up from something I said. So yeah, when I meant more advanced, I meant in terms of positive cases earlier. I think we all remember, the outbreak in Italy initially, and then it obviously spread throughout Europe. Not to say that we didn't have it, but case numbers were higher earlier on in the pandemic in those countries.
Yeah, and Anna, did you want to add something on that?
Yes, I know that there was a question in regards to how Germany has dealt with contact tracing, I believe. So I know that Germany has started contact tracing very early on in the pandemic, earlier than most other countries. And I think they had over 400 call centres from the very beginning of the pandemic scattered in Europe. In Germany. They were set up by local health departments, and there was one contact tracer where the goal was to have one contact tracer per 4,000 inhabitants. And I think the contact tracing was key to the strategies Germany has taken to flatten the curve. So that's all I can say about that. Yes.
Thank you, Anna. I think the contrast between very centralised and more local approaches is being seen in many parts, and certainly we're experiencing some of that here in the UK as well. A more general question, and Lauren, this might be one you could pick up, is there ongoing research or evaluation and plan to look at the indirect impacts of the cost of COVID in Wales, do you know?
Yes, so we are doing some work on that within the team. So we're looking at, so for example, the cost of hospital admissions as a result of the outbreak. We are due, as part of another project that we're doing, to do looking at health equity in Wales, and we're due to publish a report looking at the general impacts of COVID in December time, so that's something to keep an eye out for, and that will look at the data, economic and policy impacts of the outbreak on health equity in Wales.
Thank you. Well, we'll look forward to that. We're coming to the end of our time now, so I really want to thank all the presenters for these very interesting talks. The importance of learning from our international neighbours has never been higher, and also for all the attendees for joining us. If you are interested in attending future events, please do sign up to the network, Public Health Network Cymru, and also keep an eye out for the evaluation, because we would like to hear your feedback. Apologies again for the glitches, so do keep your lookout for the on the website for when we load up the recording at a later date. Thank you all very much. Hwyl fawr.
Thank you. Thanks.